Hey everyone, Devin here. For our CoFIT class on Wednesday, May 27th. Today I'll be doing a class on something called NDT, Neurodevelopmental Treatment. I'll kind of preface that by thanking everyone who's joined us so far and encouraging anyone watching this today to share and spread the word to people who you think might be able to benefit from this. So, and I'll add that, as we have in the other videos, that this is information in this video doesn't constitute medical advice. It's just for educational purposes, and if you have doesn't substitute an evaluation by a skilled medical professional. So, that being said, if you have any pain, if you're going through any of these movements, please stop. Don't push it, and consult a medical professional. So we are available to that end. Offices are open. So that being said, I'll introduce myself a little bit. So for those of you who don't know me, I'm Devin. I'm a physical therapist at Robbins Rehabilitation. I have an undergraduate degree in biochemistry, and I also have my doctorate in physical therapy. Today's topic is something I'm really interested in. It kind of brings together a lot of different, perspectives, and when it comes to thinking about the human body and how we move, and really just integrates things together. So without further ado, I'll kind of give you a little introduction on what NDT is, neurodevelopmental treatment is, and then how that applies to what we're doing today. So I'll start off by saying that human beings, we're made to move. We're bipedal, so we walk on two legs, but we don't come out of the womb walking, right? We have to learn to walk. But when you think about how that happens, how a child goes from not walking to walking, it's kind of a sequence that takes place. That sequence is called, has a term, developmental sequence is what it's been termed. And it's really important that a child essentially make its way through the sequence, because all the different movements in the sequence, which I'll get to, some of those, in fact, I'll just list them right now. So the developmental sequence is the progression going from lying on your back, which is also known as supine, lying supine, to being able to roll, to being able to be prone, which is lying on your stomach, to then working up onto your elbows, to then being in a hands and knees, or what we call quadruped position. And then from the quadruped position, being able to go into kneeling, squatting, eventually pull yourself up, verticalize, as they call it, pull yourself up into standing, and then eventually that leads to walking. So that's what the developmental sequence is. And now, having defined it, it kind of goes without saying it's very important that a child is able to do all those things, because in adulthood, those things are very functional. Doing each of those things is important. But what's also really important is that each of those movements in itself has carryover to other movements. So, for example, the rolling movement has a really good carryover or association that you can make to being able to stand on one leg. The amount of rotation that should occur of the human body with what we call segmental rolling is really can be an indicator of how well you can stand on one leg. So there's all sorts of carryover between these different movements. And on another note, in speaking of kind of the importance of and the innateness, or how much these movements are part of us as human beings, is that these movements are really hardwired. So we have reflexes called developmental reflexes that are essentially certain stimuli or something in the environment happens, and we feel it. So I'm speaking as in terms of as if I was an infant right now. You feel it, and that provokes a response. And that response is not something that we consciously think about. Think of the knee-jerk reflex when you go to the doctor and they hit your kneecap and your leg shoots out, or should shoot out to some degree. There's similar arcs, we call them reflex arcs, in children who are developing. And these different arcs are present in all normal developing children, and they help us to actually go into these different movements, okay? So in that sense, some of these movements are very much hardwired into our kind of being and nature. So why am I talking about this now, and what is NDT? Well, what experience in rehab has shown, particularly in the rehabilitation of individuals who've had traumatic brain injuries, cerebrovascular accidents, so strokes, any type of neurological damage, spinal cord injuries, that these neurological patterns kind of break down. So that the pattern, so to speak, when we're talking about these movement, we call them movement patterns, that by definition is a series of muscles moving at once. And what provokes that, or what causes that movement? Well, it's the central nervous system that, your intention, and you want to reach for something. The muscle don't move on their own. There's the thought, the idea to accomplish a goal. Well, what happens when in neurologically impaired patients is that some of these patterns, or if you want to think of it in terms of the hardware, the specific nerves in the brain, and the nerves that usually work when you move your arm or your leg, or in a certain way, or reach for something, they don't work. So what this kind of came to light a lot in neurologic rehabilitation, and they noticed that when they're trying to rehabilitate these individuals, rather than just focusing on the muscles themselves and movements of just to focus on the muscles that they noticed were weak or were tight, rather than doing that, they had much more success in restoring movement competency, so the ability to move, when they worked in these patterns. Okay, so that's kind of the crux of what NDT is. Again, it means neurodevelopmental treatment, and it's essentially approaching movement and using the normal development of a child as the benchmark for how we should move. And so this can have some carryover into orthopedic or adult populations as well, without any obvious or severe neurological injury. The process for how that happens is, quite frankly, we don't spend so much time in some of these positions as we partially as we age, partially because of maybe some injuries, or also in part because of just the demands of society. So we don't spend time in these positions, and if you don't use it, you lose it, okay? Or we become less fluid or competent in it, and that can kind of drive further loss of function. So what all of this kind of comes down to is, a lot of times in the outpatient world, my experience, I see a lot of clients who they may come in with a particular ache or pain, and that's kind of their driving complaint. But when I look at their movement, I fundamentally see that maybe I'll find quite often that one of these patterns has broken down. In other words, they can't do a certain pattern. And if I incorporate some of this pattern-based movement training into their treatment, I have some good results. So what we're going to be doing today is basically going through the movements in developmental sequence. It sounds pretty simple. If you saw the title of the class or the caption description of the class, it might not sound like much of a challenge at all, but you'll find that it's somewhat harder than it looks. So in particular, if you've perhaps had past injuries, or if you just don't get into these positions quite often. So I'll just say that today's going to be kind of an exploration. Notice not just the difficulty of the movements, but how you feel while you're doing them. Note your breathing, any different side to side, because we'll be doing both sides. And use this as kind of a benchmark for movement competency. Not the end of the world if you can't do some of these movements, but it can kind of be an eye-opening experience when you try to roll on your stomach, it doesn't feel comfortable, or you try to do a segmental roll like we'll do in a second, and it's very difficult to do. So that being said, we'll get started. So the first movement we're going to do is called a segmental roll. Okay, so the idea behind a segmental roll is that your body moves, you guessed it, in segments. Okay, so you don't just roll like a log like we normally, like you might normally think of rolling. The body as a unit. You kind of separate the upper and lower half. So I'll demonstrate what this looks like and just try to follow what I'm doing. I'll do it a couple times and I'll talk you through it, but sometimes it's just easier to watch a little bit. So there's a couple different ways to do this. You can lead either with your legs or your arms. I'll lead with the legs first, and I'm going to try to move the lower body independent of the upper body. So I'll try to roll to my left first. I'll reach my leg across. And I'll roll over onto my stomach. And I'm going to try to roll back. Reach my leg across. Roll onto my back. So what the heck did I just do there? Well, what's the big deal with this? So part of the key when it comes to rolling is that you shouldn't really be exerting yourself that much. You should be able to just bring the leg or the arm across your body, let it fall, and gravity should kind of bring your torso along with it. The force of the leg should bring the torso along with it. So what I'm doing right now, or the ideal, I'll show from a different angle. I'm bringing my leg across my body, and if you see my torso, I'm not really pushing. I'm just letting my leg pull me across. Okay, and when I go back, it's important to have the side that you're rolling to, so I'm rolling to my right side now, to have that arm flat, otherwise the arm's going to be a barrier. So have that arm flat. I'm reaching with my leg across. I'm not pushing with my arm. And I'm just following through. Across and following through. So you might think of, if you may or may not be having trouble with this, but you might just kind of sit and reflect and think of, well, does a baby really need to think about how to roll? Not really, they just kind of do it. But if you do watch them, they don't really log roll. They roll segmentally. So I'm going to show an upper extremity, so an arm leading the roll with my arm. So put my left arm over my head, and I'm going to try to reach and roll across, bring my torso across without really driving into the ground with my legs. Okay, so I don't want my legs to really help me with this one. Just want to kind of lead and follow. And then this next one is kind of tricky, so you're going to try to roll back with your... So that's a little bit more difficult for me. So I've been talking about how, I don't know how well you could see that, but that was a bit more challenging for me. Part of that is just my mobility. So I don't have the best, just in terms of speaking of how far I can reach and the accessibility of my shoulder and thoracic spine rotation. It's not that good. So that's going to limit me. So when we talk about these patterns, and I'm talking about the neurology of them and the hardwired kind of the circuits and neurons and all that jazz, it's important to remember that also eventually the kind of the hardware changes. So the actual tissue changes, and that can be a limiting factor too. And that's kind of more often what we see in adulthood or with our adult clients. But those two things really do go hand in hand. So that's what a segmental roll looks like. I just showed rolling to the right, but you could do it going to the left just as well. And you, more often than not, will find a difference side to side. Okay, so the next natural progression from rolling is to be prone. So I'll show you. We just rolled. And now we are prone. Okay, so what is being prone? Prone in itself is pretty simple. orthopedically or musculoskeletally, you just really be aware if you have, it can be a sensitive position for someone with, in some cases, with back injuries, but usually, I mean, it's a position that should be accessible to us. So it's just lying on your stomach, trying to be relaxed. It takes some amount of strength of your extensor muscles, so the muscles that keep you upright. But other than that, this is more of a static position. So you're not really moving when we're thinking about it in terms of what a child goes through. The rolling, the first thing is lying on your back, which most people can do. And then the rolling is kind of the transition to the next phase, which is prone. Okay, so this is, I kind of skipped one. Prone would be if I was just completely flat. This would be prone on elbows. I'm assuming that most people can do prone on elbows. And in this position, just kind of note, what do you feel in your back? What do you feel in your hips, abdomen? Is your breathing impaired? So I was just kind of taking a breath there. And I feel pretty good. This is a good position for me, but it varies person to person. If it feels uncomfortable, don't try to put any specific reason why. Just kind of kind of pass your awareness to where are the areas of discomfort, and just note that. So the next position to get into, I'm going to move the camera back up, is quadruped. So how does a child get on hands and knees from being prone? Well, they push themselves up onto hands and knees. Okay? So this position there's not too much to this position. In terms of being able to tolerate it, it mostly just amounts to the weight-bearing pressure, being able to maintain having body weight going through the kneecaps. But otherwise in this position, I mean, what do you feel? I feel pretty good. Things to be aware of are just kind of what's the position of the spine. So if you look to the side, we've used this motion in some of the other videos we've done. But you just kind of, just a normal flat spine, no real extreme in motion. And again, it's just an awareness, okay? We'll find that a lot of these movements, if you've been to a physical therapy location, take advantage of these positions to do different movements throughout a rehab program. And oftentimes our decision making on what exercise to choose for certain clients amounts to, all right, well, how well can they get in these fundamental positions? If they can't get into one of these, we'll regress it. We'll go to what we would term an easier one, or an earlier in the sequence. Or if they're able to handle these movements pretty well, we'll progress it. So we'll go to a later on, more advanced movement in the sequence. So something to kind of keep in mind, just for food for thought, is think of how the hierarchy of the difficulty of these movements, these positions, as we've been going along, kind of started off pretty simple. It means lie on your back, supine. There's really not much to that in most circumstances. So now we're getting on to quadruped. Okay, so quadruped is the other name for, the fancy name for hands and knees, and it takes a little bit amount of control. So I'm going to get back into that position. Okay, so there's plenty of different, as a child grows, think of what comes next after quadruped. Well, this is super important to be able to crawl. I mean, you can't crawl if you can't get into this position. So so I'll kind of show you from the side. When you have a crawling pattern, okay, so when the child's crawling, they're able to move one arm with one leg. So opposite arm, opposite leg. So they'll reach with the one arm and follow through with the opposite leg. So right arm, left leg, left arm, right leg. And they go forward and backwards. Okay. You don't see what we call a ipsilateral pattern, so same side, same leg, same arm, same leg, really at the same time. It's kind of counterintuitive when it comes to developmentally growing, but that is a pattern that is used in rock climbing, things like that. So, but in terms of the purpose of this class, a child is able to be in this position, it's able to crawl, and it's able to maneuver in and out of the hands and knees position, and that's essentially what crawling is. So the next step, if you think of what does crawling prepare you to do, crawling eventually prepares you to walk. When you walk, opposite arm moves with opposite leg. Crawling is part of, in some sense, part of the first step to that. So what kind of comes next in the sequence depends on the child, but in most cases, what you have is the position, at the very least, the position we call plantigrade. So plantigrade is when we use modified plantigrade a lot in the clinic, but plantigrade is when you're basically on hands and then your feet are straightened out. Okay, so it's a little bit more challenging. You don't always see children go right into that, but what you do see usually is from that quadruped position that they'll go into a half kneel position, or at least a tall kneel. Okay, so the natural or easiest way to think about it is you're on hands and knees, and eventually you're able to get into rock back on your heels, and you're in a half kneel position, a kneeling position. And then if you just extend your hips up, you're in what we call tall kneeling. So once you're in tall kneeling, what does this feel like? For the purposes of the class, just kind of note what you're feeling. Okay. So hips should be relatively straight. Feels okay to me. I don't really feel any discomfort, but again, just note it if you do. And the next step in developmental sequence from tall kneeling is bringing one leg out in front, and this is called a half kneel. Okay? So just note side to side without leaning like I am. How easy is it to get from tall kneeling to half, side to side? Are you shifting to get that hip up, or is it relatively an easy change? So again, this is a position we use quite often. And developmentally speaking, we'll go to the next movement, which is the most advanced and probably will be the hardest. There's a lot of different reasons why this next movement is difficult for us, but as adults in Western society, but I'll kind of spare the lecture on that. So the next movement is the squat. So if you can get one leg out in front of you, the next is to have both, okay, and to sink back onto your heels. So I'll show you from the side kind of what this looks like. So think of seeing the babies, they kind of have a very, even I'm losing it a little bit, I have a little round to my low back, but they're able to maintain with almost perfect form, position of the hips, knees, low back, and they're able to sit back completely into the squat and get right back up. You see, I need to push myself up. But that's the next step. So that may be very difficult for some people watching the video, but just try it. If you can't access that position, there can be many reasons why. It's a very taxing position from a mobility perspective. You have to have the mobility in the ankles, the knees, the hips, and the spine to put it all together, and then have to have what we call motor control, or the ability to coordinate your balance and the activity of those muscles to stay upright. So, but this is kind of what an ideal squat should look like, and I'm not the best poster child for ideal squatting, but this is kind of ideally a child would have. They wouldn't be reaching forward like this, like I have to. I kind of have to maintain my balance. And in my case, it has a lot to do with my mobility. But for some people, you might not have a mobility problem at all. we might be able to stretch you all over the place and not find a problem, but then we try to put all those motions together and it's a bit more difficult. So, but for a child developing, the squat is the natural next step in getting vertical. So once they get squatted, sometimes even when, and it doesn't, I should qualify everything I've said by a lot of times the order in the sequence can be interrupted, or they might skip one, but eventually they, under normal circumstances, normal development, they'll hit kind of all these different movements, and they can't really perfect the next movement or the more complex movements without being able to do all the ones in between. So what kind of comes next after the squat? Well, the child has something to hold on to. They pull themselves up and they hold something, and that's called, once they get upright and they're standing, verticalization. Standing, it doesn't really need, I would hope, much of an explanation. But once they do get standing and they move side to side, that goes into what we call cruising and things like that. But the squat to the stand, again, they have to have control of the lower part of the motion before they get to the top of the motion. So as you squat like that and explore these movements, don't have to close the book on it once the class ends today. You can keep playing around with these movements, again, respecting kind of what you're feeling with the body. But are you having difficulty with these positions? Because they really are fundamental to our existence, plain and simple, and our ability to move. Part of the reason I also like to talk about these things is we spend so much time, so much focus on standing, sitting, and postural things in the rehab world, when part of the best way to address those things is to use these patterns, these ingrained kind of hardwired things that we've been discussing, these ingrained, I shouldn't say things, these movements, and use them from both top down and bottom up. So a lot of times, an example that comes to mind is if someone's having trouble, a client is having trouble in the clinic, and it's difficult for them to squat. A lot of times we will try to teach them how to go from a standing position to a squatted position. So we'll try to teach them going from standing to squatting. And a lot of times, some people do really well with that, other people don't. What I like to do if a person doesn't do so well with that top-down approach, I'll switch to a bottom-up approach. So I'll look at all of these developmental sequence movements, and more often than not, I'll find they can't do one of these movements, and I'll work on that, and then work my way back up from a bottom-up approach to be able to get from a half kneel to a squat, and then go from squatting to standing rather than standing to squatting. So anyway, we went through all the movements. Feel free to watch this video again. If you can't remember, again, I'll just go through them. It's first movement is rolling, prone elbows, quadruped or hands and knees, Plantigrade, which we didn't spend too much time on, but that would be this position here. So the way that kind of factors in is sometimes you'll see children, they go to Plantigrade and they walk themselves right back into a squat, but it's a little bit more advanced. We went over the squatting, went over tall kneeling, half kneeling, and standing. Walking, we didn't go over, but that's the goal of the developmental sequence, if you want to think about it from a goal perspective. So consider this as kind of a competency screen. So quick, plain and simple. Can you do these movements? Can you not? Are they difficult? Are they not difficult? What do you feel while you're doing them? Use this information, and I hope it was helpful. Some of this is hard conceptually to wrap your head around, and it takes a little bit more of an understanding of the complexity of human movement to appreciate, but I hope I was able to distill it in some way. If you can't do any of these movements, I would suggest come and see us in the office. And even if you're not having pain, being unable or having difficulty with any of these movements can be a predictor of not necessarily an injury, but some type of what I would call a dysfunction. So something not working right. And sometimes it could be an easy fix. And we have a free movement screen program at Robbins. So feel free to take advantage of that. So let me double check through my notes if I didn't miss anything. And I think that's everything. So thanks so much for tuning in today. If you know anyone who couldn't make it and you think might benefit from this, direct them to our Facebook page and have them like the video, watch the video, subscribe. We want to continue promoting these videos, but we also want to provide good content for you. So if you liked, didn't like, leave a comment, and any suggestions we'll gladly take. So that being said, I'm going to sign off. I hope you guys had some fun. Hope you learned something. Till then, stay safe, stay strong, stay positive.